somebody with foot pain if we don't have it ourselves. Okay, so here we go. So again, my name is Meredith Warner, and I'm an orthopedic surgeon at Warner Orthopedics and Wellness in Baton Rouge, Louisiana. And today I'm going to talk to you about heel pain, plantar fasciitis in particular, which is one of the more common reasons to have heel pain and one of the more well-known. Unfortunately, poorly named in the past, but it is what it is, and I'll explain that a bit as we go on. Okay. Next slide, please. We're having technical issues. Hold on. Oh boy. Well, let me tell you about it. With that went really fast. Okay, hold on. We're getting back to the beginning of the talk now for you. All right, so this is my clinic, sort of everything we offer. I try to offer full body, whole body person care. I have a number of patients that come see me who tell me that they're so tired of having a shoulder guy and an elbow guy and a left pinky finger guy and a middle knuckle on a Wednesday guy. That's how subspecialized medicine has become. And to be fair, I'm subspecialty trained in foot and ankle surgery, particularly complex, diabetic, those kind of problematic foot and ankle issues, bunions, things like that. But at the end of the day, I'm still an orthopedic surgeon, and I love natural medicine and science in general. So I do have the capabilities, particularly with my team, to do whole body care. Because the human body doesn't exist as separate pieces and parts you put together every morning, and pick and choose. Unfortunately, we're all linked and we're all one big complete picture. And you have to remember the linkages when you're trying to make somebody feel better. So, all right, moving on. Or not. So one of the things that we offer in my facility is I try to make it as healthy as possible. And one of the things, this is how much whole body care we do. We not only offer total body care, but we will even use things like aromatherapy, daylight spectrum. All my lights are daylight spectrum because that's much more healthy and gets you to focus and work better on your health during the day. A lot of natural light also been shown to be very, very healthy. UV rays kill bacteria and viruses on site. So we've put a lot of thoughtful elements into this facility to make it as healthy and as promoting of wellness as possible. All right, let's talk about one of my favorite subjects, which is plantar fasciitis. So what is it? This is named itis, right? Itis is a Latin derivation of inflammation or swelling. So when plantar fasciitis was originally named, plantar is the term we use for bottom of the foot. And then fascia is the thick band of tissue, thick meaning width. The thickness in terms of the differential from the bottom of the floor to the top of the foot is really only about 3 millimeters. And then itis is inflammation. So an inflammation of the fascia on the bottom of the foot. However, we've since learned that it's not a true inflammation in the way you think of inflammation, like an acute injury and it's red, hot, swollen, and painful. Rather, it's more of a chronic inflammatory condition. So probably a better name would be fasciosis, but that just doesn't sound good. So we'll just keep with fasciitis. So it's an irritation of the fascial tissue, we just talked about that run under the arch of your foot and into your heel. And this pain, most people will describe as being much worse in the morning and also after long periods of stillness. So after long drives, after sitting at a desk for a long time, any time period that allows the fibrous tissue and the fascial tissue and the the fibrocytes and all of the structures of the collagen protein that form these structures, when they're allowed to contract and stiffen and just get generally cold, I guess, then when you hit them hard with the first step and you suddenly apply a extreme load and force, that's when these fibers instigate their pain signals to the nerves around them. Most true plantar fasciitis will feel better after activity. So if you have severe pain in the morning, it gets better with activity, gets worse after periods of cool down. That's getting close to true plantar fasciitis. The pain can last up to 2 years, the natural history. Usually most people think of about 12 to 18 months for the natural history, like if you did nothing. Some people get lucky, it gets better in a month, but some people it goes to about 2 years of on again, off again, severe heel pain. And it's unfortunately pretty common, 10% prevalence in the US population. So that's a lot of people. So for every 10 people, somebody has heel pain. So what does it feel like? So most people say they have a stabbing pain on the bottom of the heel on the inside aspect. So in between your legs, that side of the heel on the bottom, right at the back. So almost not where you heel strike, because traditionally you heel strike on the outside part of the heel, but as you roll over your heel to accept the floor and your foot kind of flexes to accept stance or get you to that standing position, that's when it hurts the most. And some people will feel a very tight sort of a feeling in the arch, or like right where the arch begins, right where the heel kind of converges into the instep. That's also a traditional strong point of pain for this. Now, some people feel plantar fasciitis out by the big toe where they interdigitate, and I'll show you some anatomy slides so you understand that better. But the fascia, the biggest, tightest, or strongest point of attachment is a heel, and then it diffusely spreads to all 5 toes, so it's a little bit less at each of those. But some people will feel it, particularly behind the big toe, right before it becomes a sesamoid bone. And then the pain can lessen with activity, as we said, but after that cool down period and you hit that floor again, the proteins that come out to instigate the pain signals in the C fibers of the neural system, they are ready and waiting, and oftentimes that pain's even worse. So some people will use the term stone bruise. That's sort of the traditional layman's term. Bone spur, a lot of people associate it with a bone spur. Jogger's heel is another term, but that denotes really more neural pain. The slide on the left has a circle around the traditional site of most of the pain, which is the attachment point of the medial band of the plantar fascia. So there's a strong, thick medial band, a bit of a less thick lateral band, and then a middle band as well. And then they all split into slips or tendon splits, like tributaries of a river. And then they vertically interdigitate into the phalanxes of the foot, so that when you bend your foot and your toes bend, you're automatically pulling on those fibers during push off. And that's by design. That tightening mechanism, and we'll talk about it a bit later, will actually increase the arch strength, increase the tightness of your arch, and make your push off more efficient and allow you to exert more muscle force against the ground, which is important for walking and running and things. So this shows you a cadaveric dissection. In the middle, you can see the plantar fascia starts at the inferior medial heel, which you see on the left. So that's, if you remove the skin from the picture on the left, that would be what you're looking at. The fiber goes along the bottom of the instep, okay, and then splits and then interdigitates. And the most frequent areas of pain, most people feel it in that medial plantar aspect of the heel, the inferior calcaneus, like we talked about, but it's not everybody, and you can see it's variable. So a lot of times it's difficult to sort of tease out what is the source of pain in somebody, because there's referred pain. The plantar fascia hurts in places that you don't traditionally think of. It'll get confused with things like metatarsalgia, sesamoiditis, things like that. So it's important to get a good physical exam and have somebody that really knows all of these variety of different presentations. Okay, so moving on. Okay, so the other thing that is interesting is a lot of plantar fascia or plantar fasciitis is not diagnosed correctly, in my opinion. So a lot of heel pain is called plantar fasciitis, whether or not it is. So, and this happens a lot, because I don't know if you've noticed this when you go to the physician, a lot of people complain that doctors don't even bother examining their feet anymore. They just look at an x-ray, they see a spur, they say automatically, oh, you have plantar fasciitis, here's your treatment plan. And we'll get into that later. So it's important to do a good physical exam, because simple tendonitis can mimic plantar fascia pain. A stress fracture in the calcaneus can mimic plantar fascia pain, has slightly different features, but oftentimes hurts right in the same spot. And then often a nerve entrapment can completely mimic plantar fascia pain, because at the end of the day, your brain, the perception of pain is simply interpretations of electrical signals from a variety of afferent fibers, so sensory fibers, one of which runs right where the plantar fascia hurts. So if you have an entrapment of that branch of the tibial nerve, which is a branch of the sciatic nerve, which is a branch of the spinal cord, if you have an entrapment of that 1 to 2 millimeter branch of nerve, your brain just simply will register a electrical signal from that inferior medial aspect of the heel. And so your brain sometimes can't tell the difference. Your brain is just interpreting or perceiving an electrical signal and telling you that your heel hurts for whatever reason. So it's really important to sort of tease this out in a treatment protocol. So again, here's some images to show you that. The left side image that's all by itself, that is a stress fracture. The top middle image is a tumor. So sometimes you can, and then the top right is also a tumor. All of these are a variety of different reasons to have heel pain. Another couple stress fractures on the bottom, and then Achilles tendonitis, which will often sometimes refer to the bottom of the heel, because if the Achilles attachment is inflamed and irritated, people don't just hurt there. They sometimes also hurt on the bottom of the heel, because think of it, it's like two attachment points to the same bone, just fighting each other all day long during stance, gait, ambulation, etc. So it's important to make sure that you don't have another reason to hurt. Plantar fascia is benign. It's not doing anything to the structure of the foot usually. It just hurts a lot. But if you have something like this, that needs to be treated a little bit more conservatively and safely, because you don't want to miss these reasons for heel pain. Okay, so what is the natural history of heel pain? What do I mean by natural history? In the scientific literature, we often, there's a lot of articles. If you go to Google Scholar and put in natural history of, pick a condition, somebody has probably written about what happens in any particular condition if you do nothing. So the natural history, meaning there's no human intervention, 90% of these should just go away. Again, it's a benign condition. It'll come and go. Some people, it's a little bit more constant, but 90% should resolve with doing nothing. The problem is it takes forever, and it's extremely painful, and it will really interfere with your life while that's happening. Now, in very rare instances, if the chronic inflammatory change and the degeneration of the fascia is enough, you can actually have a rupture. But really, ruptures more likely happen if you've sought treatment and had, in particular, a steroid injection. That's when these plantar fascias tend to rupture. The pain often causes deconditioning of the rest of the body. So you may want to exercise for your cardiac health or your brain health, which of course you should, because exercise has been shown to extend life, prevent cardiovascular disease, and prevent neural degenerative conditions such as Alzheimer's and whatnot. But sometimes this pain keeps you from exercising. So sure, 90% will resolve, but if you can't exercise for 2 years or do your normal job or take care of your family, that's probably not a good option for you. And again, poor performance, so presenteeism. So chronic pain is a source of presenteeism for a lot of people. You may show up to work, you may show up to dinner, or you may show up to your family, but you're in so much pain that you're not really there. You're not on your A game, so to speak. And then altered relationships. So the foot pain, severe foot pain, like from plantar fasciitis, has been shown to reduce quality of life as much as things like bad hip arthritis and bad knee arthritis or severe low back pain. So it's right up there with all of these conditions that reduce your ability to perform and also change your mood. So 30%, 1 out of 3 of these people with severe foot and ankle pain will have mental health issues such as anxiety and depression. And then we all know that chronic pain can be very life-altering. So why treat it if 90% resolved? Well, I think I just went through that list for you. The natural history does indeed tell us that most will improve. So if you are an insurance company, of course, you're going to say, well, this will get better on its own, so we're not going to cover anything. Sure, that's true. We won't talk about the insurance business, but generally speaking, most third-party payers aren't really concerned about how you feel going about your daily life, or if you're present, if you're not having presenteeism, or if you're happy and fulfilled and not anxious and depressed from your pain. So remember that it's very cheap to not treat. So most people are going to go that route, but it's maybe not the best ultimately for you. Certainly probably not the best for you financially, because you're not going to be able to do what you normally do. You won't be as effective. But the evidence for most forms of treatment in defense of the insurance companies is not super, super strong. So a lot of the studies that have been done are small series of a few patients, the single surgeon reporting on their own surgical outcomes retrospectively, meaning they're not even done in a prospective randomized manner. But that's the evidence we have, so we have to go with it. Our goal, my goal, is just to get you better faster. I think that's a goal of most orthopedic surgeons. We know that you'll get better on your own eventually, but our goal is to sort of speed up or hasten that process if we can. So the number one best way to prevent or treat problems, or I guess the best defense is a good offense, is to be preventative, right? So if you could prevent this from happening to begin with, then you don't need to watch talks like this, and you don't need to have the pain, right? You're just already better because you never got bad. So a lot of people will tell you don't wear unsupportive shoes, and that's a reasonable first goal. You want something firm and supportive, meaning that it would allow you to also build your foot strength, because ultimately you need a strong foot to prevent most foot and ankle problems. You need a flexible heel cord, flexible connective tissue that's able to accommodate different loads and different rates of load, and you need good, strong bone, okay? So bone health is important to reduce foot pain. You have to have strong muscles. So footwear is important, but in my opinion, strength of the foot is even more important. So you want to avoid shoes that will either fully encapsulate and not allow any foot muscles to ever work. You want to avoid shoes that are too squishy and soft for the same reason. They kind of change the way the moment arms of the different muscles work and they reduce strength. You want to avoid excessively deforming shoes like high heels. And I want to say, put a little caveat on that. I know you're going to have to wear high heels sometimes. I do too. So the times that you can wear high heels, or you have to wear a high heel, or you want to wear one, would be fine as long as you've developed your foot strength and protected your foot otherwise. Just like anything else in the human body, a little bit of stress is probably good for it. So maybe putting on that heel periodically works different muscles, and ultimately isn't detrimental, assuming you've taken care of it otherwise. Over exercise. So what do I mean by that? You don't want to get a stress fracture. Like you don't want to go out there and try to run 10 miles if you're out of shape and overwork your foot. Over exercising just implies that you have not achieved a level of conditioning to support the activity you're doing. Once you've avoided that or achieved that level of conditioning, you can exercise that much. So in other words, I guess what I'm saying is improve your foot strength over time. Remember recovery time as you do that, and your foot will get stronger, more of a fatigue resistant, and you'll have more endurance, and you'll be able to do more during the day with less pain, and then wear your fancy shoes when you feel like it. And this includes dress shoes for men. A lot of the dress shoes are very tight, hard leather. They don't accept or give or allow for foot movement, and they're kind of uncomfortable too. And then the biggest, most important thing for your fascia and your foot is to avoid chronic inflammation and oxidative stress. And we've talked about this in other talks. What this means is the inflammatory cytokines that a poor diet, pollution, mental stress, things like that will produce in an ongoing chronic low-grade basis. Remember, I told you at the beginning of the talk, fasciitis doesn't mean the acute inflammation that you're used to. It rather now can denote chronic inflammation or inflammatory changes with things like tumor necrosis factor alpha, interleukin-1, interleukin-6, all of these very pro-inflammatory markers, the same ones you see in things like rheumatoid arthritis, and lupus. They're running around at a low-grade level in our bodies, secondary to bad diet, all the time. And that's what damages your connective tissue, as well as things like advanced glycation end products, which we'll probably talk more about in the future. So if you can avoid a bad diet, take care of yourself, eat very healthy, you'll probably prevent a lot of your pain as well. So foot strength is the best. And I've just put on, looks like one of my pictures got cut off. I apologize for that. So this is just a simple exercise. Sitting, right? So this is if you're just starting out to condition your foot, right? You're not even picking up your whole body weight with this exercise. You could obviously get more and more progressive with this. You could get up to a high number of reps up, down, sitting, and then start with low reps standing or wall on a wall sit. So some of your weight is supported on the wall, but some's on the foot. So this is going to work the long extensor muscles to the foot, right? And then the tibialis anterior to pull the foot up, and the gastrocsoleus complex to pull up on the Achilles. So the foot is not just a foot, you also have to strengthen the ankle, and this is part of that. Lifting the foot like you see on the picture on the right, that's going to strengthen the front where most people get shin splints. So you need to do that before you start a conditioning program. Get all of the core strength of your foot stronger. Go to the next slide. That's showing you that exercise. It's very simple, but it does a lot for people, particularly if you're weak and deconditioned coming off an injury or surgery or something like that. Next slide. Okay, here we go. Here's some more exercises. So this is what's called a TheraBand. So TheraBands are a great physical therapy tool, and each color denotes a different amount of elasticity. And so you can have a very flexible one that is going to allow you to do high reps with low resistance. And then you'll progressively increase the tightness of the band, which basically mimics heavier load or heavier weights. Okay. So great tool to use. Your physical therapist should have these. And then you can get these as well, I think, online. But one would be put your foot down, hold the TheraBand, and you just start everting your foot. So you're working the outside long ankle muscles doing this. In addition, you are working some of your foot intrinsic muscles, the muscles that are within the superstructure of the foot itself. The one top right is showing sort of a Tai Chi move. In this case, they're seated. So you're inverting one foot and everting the other in a coordinated sort of way. And you could progress this again to wall sits and do it, and then progress it to standing. This not only stretches your ankle, improves your balance, but also dramatically improves your strength. Obviously on the bottom, now we're working the tibialis anterior again, but we've added resistance, right? So in the first slide, it was just against air. And then you could, of course, hold it tight and do like an isometric. This is going to be with resistance, and then you could grade up the resistance, okay? And then the bottom right is showing you like working on agility and deftness, and that sort of trains your intrinsic muscles of the foot. All of these are important, really just to build your foot strength. Most of us, particularly Americans, because we're wearing shoes all day long, and a lot of our shoes are very constrictive, too heavy, too bulky, too supportive, and we never build our foot strength. So support is important, but you cannot remember to work on your foot strength too. So different stretches for plantar fasciitis relief. Towel stretching. So in the morning, if you have this condition and you want to stretch your foot, you just put a towel or a sheet around the ball of the foot and you just pull. And you're going to be stretching the heel cord, right? If you keep your knee bent while you're doing it, you'll be stretching the soleus and then extend, and you'll be stretching the gastroc a bit more. So you could even keep it tight on your foot and then flex and extend your knee. This one is a tissue-specific plantar fascia stretch. So pulling up on the big toe will engage what's called the win-loss mechanism. The plantar fascia will pull around the bottom of the toe and tighten just by virtue of that upward bend of the great toe. And this happens every day when you're walking, okay? This is a good way to do deep tissue massage on your own. And you could sort of advance. You could start with a squishy tennis ball or rubber ball, go to a lacrosse ball or a tighter tennis ball, then go to a golf ball. So you can have different grades of reducing the contact of that deep tissue massage ball and reducing the contact pressures by way of changing the stiffness of the sphere itself. And then, I mean, I guess you could even get those big ice cubes they use for fancy cocktails and roll your foot around on an ice ball. A lot of people will tell you a water bottle frozen, but an ice ball is a good option too. So stretching your foot and ankle yourself, strengthening it yourself. These are all things you can do yourself. But I'm a huge fan of guided, structured fitness programs and physical therapy, and we're going to talk about that later. So this is a great picture on the right. This is the Tarahumara, I think I'm saying that right, Indian tribe. They have this annual 24-hour race that they do, and they basically run barefoot for an entire day once a year. It's sort of it's a tradition amongst their people, and this is what they wear, and none of them have foot pain. None of them have any complaints. They don't have any injuries, and they're able to run all day long. So it kind of shows you that maybe some of the shoes, the running shoes out there, could be overkill, and this is where that whole minimalist running movement came from that perhaps you're aware of. But the whole point of this slide is to talk about strong feet again, because I think that you don't hear about it enough. High load strength training, so that means like low rep, high load, like you're not going to do high load for 30 reps, will improve outcomes in plantar fascia. So in the course of treating it, if you strengthen those foot muscles, you've automatically strengthened the shock absorbers and the load modulators in your foot, and it'll help your pain. And foot strength and stiffness are indeed related to what you wear on a daily basis on your foot. Countries that are generally barefoot and generally use minimalist shoe designs tend to have fewer flat-footed people. So it is important, for instance, children should be barefoot as often as possible because it helps to develop the arch. Now, of course, there's going to be exceptions to that, and obviously you don't want them running around on gravel and whatnot barefoot, but developing foot strength is important for growing feet, and then also important for adults. So the societies that use fewer constrictive shoes all the time have more normal shaped feet, so to speak. Shoes with extreme arch supports and restrictive toe boxes will weaken your foot over time. Why? They don't let the foot muscles move. I mean, imagine if your arm was locked in a cast like this all day. Don't you think it would get weak? It probably would. Same things happen in your feet that are in tight, constrictive, supportive, non-mobile shoes all day long. So foot strength is extremely important. This picture on the left is the shoe that the winner of the first Boston Marathon wore, and he did pretty well in that. Doesn't look too supportive, does it? And then the right is like the new, latest, most supportive version of whatever brand of shoes that you're supposed to wear if you have heel pain. So kind of two different philosophies here, right? Two different schools of thought. And there's a whole long history of footwear development or shoe development. A lot of it's political, a lot of it's money driven, as you would imagine, and a lot of it's just groupthink. But I just want you to remember that I think his name was McDermott. That's the guy that won the Boston Marathon, the first one. That is what he wore for 26 miles running on streets, and he did fine. So foot strength is hugely important for plantar fascia pain. Okay, so modern shoes might be a problem. It's a thought, something we should all think about. Cushioning, large arch supports, restrictive toe boxes. Sure, they provide comfort and protection. This is why I often tell people I don't really want them in squishy shoes when they have heel pain. I want them to work on their foot strength. People that wear minimal or no footwear have higher arches, better arches. They're stiffer in stance during ambulation. And that arch imparts a more efficient foot that lets them generate more power during push-off, during ambulation and running. Okay? And then how, regardless of why we began to run in an evolutionary sense, and there's a lot of debate about this, like, did humans run all the time, or did they sit around most of the time and then occasionally get up and chase a deer? We don't really know. There's evidence going either way. There's a great book one of the Harvard professors wrote called Exercise that talks about this. But whatever the reason, we know that, for 10 million years ago, however many million years ago we started running, probably we didn't wear shoes. Or if we did, we wrapped some leaves around our feet. So the foot is capable of doing this. I think the game changer is probably concrete and cement. So we do need to account for that. But you don't need to go overkill with your shoes. Or if you're going to wear big cushioned shoes when you're running, like Hoka's or the big cushion Nikes and stuff, or the ones that have all this extra bounce built into them, maybe wear something that strengthens your foot with that. And this is a great picture on the right showing you different muscles on MRI on cross section corresponding with the anatomic drawing. So the top is the abductor hallucis, then you've got the flexor digitorum brevis, and then you've got the abductor digiti minimi. These are the so-called intrinsic muscles of your foot, or some of them, that are controlling sort of all of the planes of movement of your foot during the day. And each of these needs to be conditioned, and you really should be able to control each of these. Okay, so just to quickly talk about the history of footwear and why people think that a lot of cushioning is needed. A lot of people focused on the vertical ground reaction force, or that force when you first hit the ground, and thought that that should be modified more than anything and ignore everything else. Thus, big, thick cushioned shoes so that you can modify. See that first spike on that graph? It kind of goes up and drops right down on that the one line. That is showing you a typical heel strike runner. Okay, so they hit the heel hard, have this huge spike in force, drops quickly, but then look, where's the real peak in force? It's later in everybody, and that's rear foot strike, midfoot strike, and forefoot strike people. Okay, the biggest amounts of force to the foot are during the phases where your foot's going flat and accepting the ground, and you're graduating to push off. That's when people really get injured, okay? When you eccentrically use some muscles, or they're lengthening with load, and you're concentrically using other muscles, and you're trying to propel all of your poundage forward against gravity and with some power and thrust in time, okay? So this is why people focus so much on the cushioning of the shoes and the thickness of the shoes, because everybody was focused on that first spike in just rear foot runners, whereas most of the stress is throughout the rest of the foot, which is why muscles matter so much, because you can mitigate that stress to your foot and reduce injuries with strength. And again, that's one of the first Nikes. If you look in the back of that picture, I love this picture. Since I have a shoe that I've developed and made, the shoe industry is very difficult and product development is very tough. And Nike is pretty cool because they started in a garage with literally a waffle iron to make the first sole of the Nike shoe. And that shows you that they just put some kind of rubber in there and made a waffle iron shape, put it on a shoe, and runners started running in it. So the foot biomechanics, again, we sort of talked about the muscles. We talked about where the plantar fascia starts, where it inserts, how it all connects, how the Achilles comes into it and drives some of the problems and some of the changes in the mechanisms. We talked about the wind loss mechanism, which is when the big toe lifts up, tightens the plantar fascia, increases the arch height, and makes the foot stiffer for forward thrust. And we talked about the difference in the ground reaction forces if you're heel strike or midfoot strike. But basically, you've got joints in the hind foot, which is the heel, the talus, and then becoming ankle. The transverse tarsal, which is sort of the apex of the arch. The mid-tarsal, which is also near the apex of the arch. And then the metatarsophalangeal joints, which are the ball of the foot. All of these move with each other in a coordinated fashion in every second of the gait cycle, okay, as you heel strike, foot flat, toe off. And the main stabilizers of all of these bones and muscles are those inner muscles. So you can see that muscle belly right under the ankle there in the medial aspect, right? That's the plantar fascia is on the bottom, but there's a muscle right above it. That's that abductor hallucis muscle we talked about, controlling the great toe. So all of these are super, super important and you cannot forget them. And then if you look behind on this picture behind the ankle, under those fibers that are going towards the calcaneus, you can almost see the neurovascular bundle. So those tubes, that's where the nerve lives. So a lot of times, remember, heel pain can be nerve pain. And so anything you do for plantar fasciitis is probably not going to work. And then the connective tissues sort of pull all of that together, of which the plantar fascia is one. So connective tissue support. So the connective tissues in the foot function to store energy during gait and to make us efficient as upright animals ambulating. The Achilles tendon stores a lot of elastic energy and the plantar fascia does too. So the arch is extremely important in making your gait efficient, reducing fatigue and allowing you to be more effective. So it's really important to have a good plantar fascia and have good arch strength. And this anatomic dissection is really pretty and shows you sort of all those different bands of the plantar fascia. And this is on the right, and how it splits, and then all of those interdigitations going up to the toes. And then the picture on the left just shows you all of the complex interplays of all of the different bands of fascia and connective tissue that link each bone to each muscle, to each joint, to each, even the skin. So it's kind of a really cool design, and it's an amazing machine attached to another amazing machine, the human body. So quadrupeds probably don't have heel pain like we do. Plus, they also don't have feet shaped like us, right? But the plantar fascia, although it can become painful, is one of the reasons that we can be upright. We can stand for a long period of time. We can switch from running to climbing to walking to crawling. The plantar fascia allows for stance with minimal muscle activity. So remember I told you it's an energy storage device. It allows a static restraint. It will hold the arch and let you balance with very minimal use of your muscles to stay upright. Okay, there's variable stiffness in this tissue. It's viscoelastic. So if you load it at one rate, it's going to have a certain amount of tension. If you load it at a different rate, it'll have a different amount of tension. So like how hard you hit the floor when you're running matters, things like that. And then of course you can modify some of this with stretching, of course. The fascia is more flexible during heel strike. It gets a little bit stiffer during push off. One of the reasons is the viscoelastic properties of the structure itself, but also don't forget that wind loss mechanism. That also will extrinsically tighten the plantar fascia during push-off. And then shod populations, people that wear shoes all the time, have stiffer and weaker feet, more injuries and more pain over time. Remember, we already talked about this, the importance of foot strength and connective tissue strength. So how can you support your own connective tissue? And this goes for everything from rotator cuff to the fascia in the back of your neck to the lumbosacral fascia. I mean, your whole body is enveloped in fascia and everything has very strong interconnections. In fact, the plantar fascia is connected to the back of your head through a long continuous line of fascia that goes from the bottom of the foot to the occiput. So that's why sometimes if you're trying to touch your toes and you can't, if you stand up and roll your foot around on a ball and relax the plantar fascia for a while and then do it again, I bet you'll be able to stretch a little bit further. And that's because you've modified that connection and lengthened the connective tissue that way. So the body can heal damaged connective tissue structures. The human body can heal just about anything, okay? But medical treatments such as anti-inflammatories can prevent that. So remember that. So if you're having an acute phase of healing, and you start popping Advil, there are some properties of anti-inflammatories that slow down healing, particularly the COX-2 medications like the Celebrex and the Vioxx, although Vioxx is off the market now. Celebrex and Mobic are probably the ones still on the market. So they can, in some literature, have been shown to slow down bone and connective tissue healing. You need to eat diets rich in vitamins, minerals, and phytochemicals and nutrients, okay? This is, I like the Mediterranean diet. Now we could go into the barbed wire debate about different diets, but at the end of the day, the one that has the most data to support it and the one that I believe in, because I'm a strong believer in whole foods that you cook yourself, lots of olive oil and phytochemicals, I say go towards a Mediterranean diet, and that's one way to support your connective tissue. Hydration is important. There's different formulas. There's the Galpin equation if you're working out, but in general, for just day-to-day water drinking, I want to say you take your weight and effectively divide it by 2, and you got to drink that many ounces of water just for day-to-day use. I think the Galpin equation is you take your body weight, divide by 30, and you have to drink that many ounces every 15 minutes during heavy exercise. So don't forget to hydrate, or your connective tissue will not like you. Supplements. So vitamin C is extremely important, not just to support your immune system and keep you from getting sick and help you get better quicker. It's a very strong antioxidant, but it's also a vital cofactor for the normal collagen cross-linking that happens during the development of fascia. So vitamin C is hugely important. I don't know if anybody remembers Mutiny on the Bounty or if they still read that, but remember they were going for breadfruit and they had the mutiny. Well, breadfruit was so important to the British Navy because it was a source of vitamin C that prevented scurvy. What's scurvy? Scurvy is a severe lack of vitamin C that used to afflict a lot of sailors and a lot of people, where your connective tissue was so tragic that people were just having spontaneous bleeds, gum bleeds, nose bleeds, and could never heal any injury. And vitamin C is that vital. Tart cherry extract, another excellent way to reduce pain naturally, sort of a similar fashion as the COX-2 inhibitors, but with much fewer side effects, and also a strong antioxidant for connective tissue health. Turmeric, another great one that helps reduce oxidative stress on your connective tissues and support the healing and reduce chronic inflammation, which also damages the fascia. Now, some people won't like turmeric because turmeric does have the ability to downregulate a certain enzyme that affects the testosterone pathway. But a lot of people respond extremely well to turmeric for pain reduction and GI health. And then omega-3 fatty acids, extremely important for your connective tissue health and really to reduce inflammation, reduce pain, particularly the EPA version. That's been shown to be strongly anti-inflammatory in many, many studies. And then PEA is on the bottom here, palmitoyl ethanolamide. How that works is it's a fatty acid amide that your body produces on demand anytime your nerve endings get irritated. So it reduces the ability of the mast cells to spew out all of their inflammatory cytokines and proteins. So that's another great natural way to reduce nerve-based pain, or at least when you think the nerves that are hurting you are being irritated by inflammatory mediators. So PEA is a great natural way to treat pain and to support your connective tissue. Okay, so here's the treatments you will be offered at your physician's office. Injections and surgery. Now remember, insurance companies don't cover natural treatments. Nobody covers wellness and prevention. No, you can get physical therapy covered for a foot core strength program, but your physician has to know how to order it and has to know how to justify it so that the computer that's doing the utilization review for your insurance company will consider it medically necessary for you. But right now, cortisone shots are probably being done, I don't even know how many millions times a day in the United States. It's covered, it's relatively cheap. You can bill for it. I mean, the cost of that is upwards of $300, particularly if you have a high deductible plan. And then the second most favorite way of treating, if you're not going to go get an injection or surgery, is to ignore your symptoms and just put up with the pain, or self-diagnose it and try to self-treat. And I know that that happens, and I have no problem with that. I'm just trying to guide you in potentially better self-treatment methods. I've seen anything from taping an onion to your foot to banging books against it. I mean, there's a million different ways for people to treat their plantar fasciitis. But remember, they only work if you really have plantar fasciitis and you don't have one of those other conditions we talked about. Okay, so what are the downsides to the often medically approved, indicated, written about, and covered by insurance company treatments? Generally, they're expensive, to be honest. Most people have pretty high copays or coinsurance nowadays. And also a lot of people have high deductibles. So you're paying for this whether it works or not, okay? They require extensive periods of recovery time often, particularly surgery. And then even with injections, you have a certain amount of downtime to reduce the risk of rupture. There are a lot of side effects. So some people will get post-injection pain for about a day. It's a benign event. It doesn't really damage you over time, but it's even more painful than the condition before. And this is when the steroids actually crystallize in tissue and those crystals cause pain. That usually goes away after about a day. And then, of course, you might have any kind of side effect with surgery. And then with steroids, there's risk of rupture, risk of skin depigmentation, and fat pad atrophy. And none of these are guaranteed to provide relief. Once you do them, you have nothing to show for it if it didn't reduce your pain, except for the bill, I guess. And then the downsides to ignoring and self-diagnosing. Again, you may not be correct in your diagnosis. Now you may be, in which case you probably should get better. And again, we already know the natural history is you're going to get better. And then remember, some of the online information is so-called fake news, right? So just be careful and make sure you truly have that and you don't have a stress fracture, God forbid, or something like that, that you could make worse with some of these treatments. So those are the downsides. Okay, and what does the data show? So let's talk about different aspects of foot health and treatments, okay? So balance failures happen more often in thick and cushioned shoes. I already told you some of the other problems with big, thick and cushioned shoes, but surprisingly, you've probably been told, oh, don't go barefoot, wear shoes all the time. Well, for some people, if you're in shoes all the time, your balance or your ability to sense yourself in space and reduce your fall risk actually goes up, because all of the studies show that if you're barefoot, you have the most balance because you have the most feedback going to your brain, telling you where you are in space relative to gravity and things like that. Even a thin pair of socks has been shown to reduce the overall ability to balance. There's a reason why gymnasts and dancers tend to be barefoot, right? Because that helps their balance and improves their foot strength. Stability improves in stiffer and harder shoes, right? And proprioception improves if you're not. There's a lot of different conflicting information, but I want to say the trend is, and by and large, most data will show that balance and the brain's ability to sense where you are in space is improved by more input from the bottom of the foot, which means being barefoot, or at least having the ability to sort of feel where you are on the floor. And the thicker and stiffer your shoes are, probably the less that's going to happen. The flip-flop that I made for plantar fasciitis, I made the surface of the shoe sensory positive, or promote sensation, to improve that proprioception sense, I should say. Okay, so static and position sense are worse in conventional running shoes compared to minimalist running shoes. Minimalist running shoes are like almost nothing on the bottom of the foot, just enough to protect you from stepping on a stone or a thorn or something like that. Or zero drop. A huge fan of zero drop shoes because that keeps your heel at the same level of the ball of the foot, which is more like being barefoot. It's more natural. The weight distribution is more natural. The biomechanics of the foot work more naturally. And as you know, I'm a big fan of anything natural. Okay, increased load is placed on the muscles with the removal of cushioning and large arch supports. So the title of that study, and this was actually a PhD thesis of I think it was a physiology grad student. It sounds worse, right? Like increased load, but that's good. That's like if you're going to the gym and you have increased load, you're able to do more. You're bench pressing your body weight or whatever. So you don't want to have the ability to get decreased load. That just means you're getting weaker. So actually, if you take out cushioning and big arch supports, you're going to load the muscles more. And if you load a muscle, what happens? It gets stronger. Sometimes it'll get slightly bigger even, and they've shown that in MRI studies, that you'll actually get hypertrophy along with strength gains. So if you are close to barefoot, so either barefoot in a flip-flop type shoe that lets you use your muscles, or in a minimalist shoe, or at least a zero drop shoe, you are going to get the connective tissue to function better in that energy sharing mode we talked about, where it statically assists you with stancing and makes you more energy efficient. And you'll get more of that spring return of energy from your Achilles and your plantar fascia and the intrinsic structures of the foot. So the more you are close to a natural way of being, like the Tara Mahara runner we showed you, the better your foot's going to function in terms of the static energy sharing function of the fascia. All right. So treatment options. What are your treatment options? Let's say you have true plantar fasciitis, and on the right is a short list of the differential diagnosis. So remember, when like people come see me in my office, I am ruling out all of these in one way or another. Now I may not say them all out loud, but in my head, this is all happening. I rule out all of the nerve sources, trauma, get X-rays, make sure there's no tumor, rule out any sort of inflammatory arthritic like rheumatoid, psoriatic, etc. And then look for things like fat pad atrophy. And then finally, maybe somebody really does have true plantar fasciitis. So the treatment options at that point become do nothing. It should get better. It just might take 18 months to 24 months. Physical therapy, that's probably my number one go-to treatment because most Americans' heel cords are too tight, 90 to 95%. Most Americans have weak feet, 80 to 90%. Most Americans have poor quality bone or vitamin D deficient. Most people don't have any extrinsic or rational control of their intrinsic muscles of the foot like you do for your hand. You should be able to control some of the foot muscles. So I think physical therapy is an excellent modality for people. Better or different shoes. Again, I'm a big fan of zero drop. Obviously, I like the flip-flop I designed, but clearly I'm biased. Drugs are an option. I'm not a big fan of drugs, as most people that come to my clinic know, particularly narcotics, not a fan at all. But we'll talk about the drugs that are often used for this. Injections, so you can either use lidocaine to do differential blocks to try to figure out the true source of the pain. You do steroids. I personally like the regenerative injections like platelet-rich plasma or PRP, amniotic products, and then stem cells, which are technically called mesenchymal progenitor cells when you get them from like blood marrow and things like that. So ECSW is electroshock wave therapy. And this is like massive, huge bolts of ultrasonic energy that basically pound the heel. You really almost have to have anesthesia to have that treatment, or at least nitrous oxide to get that done. It does have some support in the literature, but it's extremely expensive, quite painful, and not as effective as things like physical therapy, in my opinion. Good physical therapy. Surgery is an option. I don't particularly like the surgery for plantar fasciitis or the ones that are described in the literature because as I described to you previously, you kind of need your plantar fascia. So cutting it is not really an amazing solution, I think. It has a whole host of other problems, but the literature supports it. It's certainly paid for by insurance, and it's certainly done a lot around the country on a daily basis. So it's well within the standard of care. Sometimes it is indicated. I just personally think there's better ways to manage it, if at all humanly possible. And then that leads us to natural, alternative, or complementary, as the government calls it, methodologies. So infrared heat, alternating infrared with cold therapy, massage or deep tissue massage, acupuncture works very well, reflexology works well, herbal natural pain remedies. We talked about the tart cherry, the turmeric, the PEA. Some people go as far as to take delta 8 THC or something like that. Topicals are very, very good because it is superficial enough that the topical creams can penetrate through the tough skin layer, the stratum corneum, and get to the peripheral nerve receptors. And then changing your footwear. And probably under PT, I should have had a subcategory of improving foot strength. So those are your treatment options in general. Drugs, I'm going to talk about that briefly. The picture on the right is sort of a physiologic rendering of how guts destroy, NSAIDs destroy the gut biome. So it's been shown even a single dose of aspirin or whatever, naproxen, ibuprofen, take your pick of aspirin's technically not a non-steroidal, but in that family of medicine, a single dose can destroy the good gut bacteria, and then you have to start from scratch. And we are now starting to understand the vast importance of the gut biome to overall health, including your brain health. If you don't have the right bacteria in your gut doing the right things, the rest of you is not working right. So every time you pop an NSAID, you are damaging that and making yourself start again at zero. Narcotics, terrible, okay? Also, I should talk about NSAIDs. Heel pain seems to affect most people in sort of middle age, 40 to 60 age group. Medicare starts at 65. The NSAIDs are covered throughout by both group health and Medicare. The problem is, as we get older, the gastric bleed risk of NSAIDs and then the cost of going to the emergency room for these things skyrocket. So I try to keep people off of these if at all possible, and prefer to go the more naturally anti-inflammatory route to reduce that incidence of gastritis and gastric bleeds. I think it's up to like 20% with NSAID use, particularly in the older age population. Narcotics, I generally don't think are helpful to your health at all. They're useful perhaps for short-term pain relief after surgery. No real role in chronic pain in the literature. Now, some people really have gotten to the point in their life where they don't have a lot of options, but I try to do things like peripheral nerve stimulators, natural medications, weight loss, modifying inflammatory mediators, anything but narcotics. Now, every now and then, of course, narcotics are necessary, but they just have been shown to have so many detrimental side effects. I think they should be avoided if possible. And then things like gabapentin. Gabapentin is Neurontin. This is a medication that modifies the glutamate excitability of the nervous system, which of course would increase your pain threshold or make you feel pain more. So if you can tamp down the nerve function and make it slower and less excitable, you're going to feel pain less. Gabapentin is a great drug for nerve pain. We use it all the time. It's non-addictive. It does have a side effect of sleepiness, so I tend to use it at night. And these are for the people where I think the heel pain is from the nerve. So what about orthotics and heel cups and whatnot? So remember I showed you that slide where you have that heel strike, that vertical ground reaction, but then most of the force through the foot is through the restive gait. Well, the maximum tension on your foot structures, plantar fascia, et cetera, are at late stance and push off, not heel strike. And a tight Achilles, remember 90% of Americans have a tight Achilles, will make that tension higher and potentially increase pain. So orthotics don't really help in any of that. The only thing that they can do is they will limit your active heel rise because you're already lifted a slight bit, right? So it reduces tension on the Achilles tendon because it makes your muscle work less hard. What does this do ultimately at the end of the day? It makes your muscle weaker and makes your tendon shorter and contracted. So orthotics are reasonable, I think, short term or in some limited cases, but I think making your foot more flexible, biomechanically sound, and stronger is better. But these have been shown to reduce pain in the short term. I personally don't recommend them for long-term use. Again, not covered by insurance. Night splints. So this functions on the theory that by keeping your foot in a 90-degree position the entire night while you're sleeping, you will keep the Achilles stretched, right? At least the soleus, because if you bend your knee, you're going to relax the gastroc. And then you'll keep the foot stretched. The problem I've found with these is compliance. First of all, it looks fairly uncomfortable. Most people tell me that. Also, they fall off in the middle of the night. For anybody that has to get up multiple times at night, like let's say you have an enlarged prostate or something like that, and you're wearing this, your fall risk goes up and it makes it very awkward to have to go to the bathroom at night. And limited efficacy in the literature, meaning they work sometimes, sometimes not. Again, fairly expensive. Sometimes covered, sometimes not covered. You may be out of pocket for it with a deductible anyway, and it's only going to give you short-term relief. So I'll use night splints periodically, but definitely not on my top tier of treatment options. The walking boot. This is a favorite of some people or physicians, I should say, for some reason. The walking boot is really only 40% effective. My issue with the walking boot, although I love the rocker bottom, and we'll talk about that later, it definitely messes with the hip and the knee and the low back, particularly if you don't have a method to increase the relative height of the opposite limb. So if the boot is about 2 inches thick and you're walking around like off kilter, your ankle's not moving, it changes all the forces across your knee and your hip because your ankle's not moving. So the theory is it keeps your fascia protected and unloaded, which it can do that, but I just think everything that comes with it is detrimental to your overall musculoskeletal health. So this is never a go-to for me unless I'm really, really worried about rupture or something like that, and I really want to protect it. But this is a very tried and true standard methodology, again, with limited effectiveness in the literature. Physical therapy, I already told you I'm a huge fan. So anything that gets you moving, improves your strength, improves your biomechanical linkages, and gets you stronger and more flexible is definitely going to help you no matter what. Physical therapy, again, is heavily limited by insurance companies these days, unfortunately, because in my opinion, it's one of the best things for us. So this is guided stretching, strengthening, and working on the kinetic chain. So my office, our physical therapist and I will determine how weak your hips are and the linkage through the IT band and the adductors and other structures like the hamstring and the quad to the knee. What is your knee doing? Down to the calf, down to the foot. A lot of people with heel pain, turns out their hips are weak. So you're just loading poorly and your biomechanics are off. And if we work on your hip strength, we can make you a lot better. Hips are extremely important to how we move in space, and everybody forgets about them. Physical therapy will dramatically compress that 18 months down to like even 6 weeks sometimes. Dry needling and deep tissue massage are awesome treatments. The top right shows you dry needling with an e-stim attached. And this is sort of targeted deep tissue massage and also stimulates bleeding and stimulates healing. Foot core strength improvement. You got to have a physical therapist that knows how to do this. And then the order has to be written properly. So your physical therapy experience has been, is, or will be determined by both the physician's belief in it, the physician's order, the physician's understanding of the musculoskeletal system, and the physical therapist's quality and how hands-on they are. So one of the problems in the literature is, first of all, most studies don't even mention physical therapy. If they do, they don't have a standard protocol. And a lot of insurance companies keep wanting to cut physical therapy, which is not good because I think it's one of the best things you can do for yourself. And in my clinic, this is our go-to to treat true plantar fasciitis and even heel pain from nerves, because there's different ways to affect the nerve function. So don't forget physical therapy. And a lot of you live in states with direct access. For instance, in Louisiana, you have that. So you don't have to go through a physician like me. You can just pick up the phone and go see a physical therapist if you think that will help you. If they end up thinking you have something like a stress fracture or something, they will refer you to a physician right away anyway. All right, injections. We talked about it briefly. Again, cheap, covered. I say cheap, but you might get a bill if you have a high deductible plan. When you get that office visit, the injection and the x-ray, you might get a $500 bill. Short-term relief at best, okay? Maybe 6 months, maybe a year, usually 3 to 4 months. More pain later, particularly with steroids. So they work short-term. Most of the time, the pain recurs, and oftentimes it's graded at a higher level than it was before the first injection. And then severe side effect profile, rupture, fat pad atrophy, skin depigmentation, and then sugar spikes for people like diabetics. And then if you get repeated steroids, like some people keep going and getting pain injections in their back or repeated steroid injections here or there for like sinus infection or heel pain, over time, a certain amount of steroids will actually depress your hormone production and do things like that to the total system and just really mess you up. So I'm not a huge fan of steroids. PRP, I am a fan of. Platelet-rich plasma, that is your own whole blood that we draw in clinic, centrifuge, concentrate the white cells in the platelets. The platelets hold all of the healing proteins and these things called exosomes. And as the platelet breaks apart, once we inject it, it releases all of these healing proteins. And you basically have this massive dose of healing that catalyzes the body's natural ability to heal. And I try to inject it into the fascia itself to really promote healing. It's been shown in head-to-head studies to last longer, work better, and have a much lower side effect profile. In fact, the most side effect you have is a little bit of post-injection pain because it induces a bit of healing inflammation. And then once that goes away, most people are fine. So you don't have those long-term irreversible side effects of like steroids. But again, PRP is not covered by insurance, but steroids sure are. So surgery. This is often people get offered surgery if they've hurt for more than 6 weeks or if they have a heel spur, right? And surgery it's a procedure. It's a fee-for-service thing. The satisfaction rate varies wildly in the literature, and the quality of the literature varies wildly. And any meta-analysis or group of studies that I find to read they're dramatically hindered by the quality of the original studies. Very few prospective double-blinded, randomized studies like this. So generally, the studies you're going to find are one guy telling you about the 9 guys he did this surgery on 6 months ago. And in those studies, the satisfaction rate is 80 to 90%, but you got to take that with a grain of salt. They still report a 6 to 8% complication, and no surgeon likes to call their baby ugly. So most of us are never going to admit to a complication, right? It's just human nature. But there's a 6 to 8% complication rate, the biggest one being foot pain that then moves to the outside aspect of the foot or lateral aspect of the foot. People will actually get stress fractures because the biomechanics of the foot have changed so much after plantar fascia surgery. Why? Because remember that big, thick band of the medial fascia we showed you in the anatomic picture in the beginning? If you release that completely, God forbid, or even half of it, you are dramatically changing the ability of that plantar fascia to act as the tie rod to your arch and to store energy, right? And then allow that static ability to make you more efficient and transfer your body muscles to forward propulsion. What happens is the arch will drop over time and then the weight transfers to the outside part of the foot. Cuboid stress fractures and fourth and fifth metatarsal stress fractures are pretty common after plantar fascia surgery. And then open release versus percutaneous release. Again, open release, 50 to 80% satisfaction, percutaneous, 80, 90%. It sounds pretty good, but I would say that a lot of those studies are not great. Interestingly, bariatric surgery, 90% reported absolutely no pain after weight loss. You never even had to touch the foot. They just had to lose weight. So bariatric surgery, if you're in a category of person that will qualify and benefit from it, I think you should strongly think about it, because a lot of joint and musculoskeletal pain just goes away after bariatric surgery. I'm talking about like sleeves and bypasses. So this shows you from the American Association of Family Practice Physicians. They sort of graded treatments and the evidence rating, and you don't see any A's. You see B's, which is, okay, maybe it works, maybe it doesn't. So this is what I'm talking about. There's not a ton of great, validated, well-studied head-to-head options, and there are no studies out there of this particular surgery versus this particular natural method of treatment, okay? And again, nobody talks about the quality of physical therapy. So the point I'm telling you is the medical options that insurance covers and your physician are going to offer you are fairly costly, and they're maybe effective, maybe not. And this sort of breaks it down. My experience, what I know and what I've seen in literature. Do nothing. I don't know what that costs, because I don't know how many days off of work you're going to have to take, what events you miss, how much less money you're going to make because you're hurting, things like that. A boot, anywhere from $150 to $400. That's that fracture boot I showed you. Night splints, $100 to $250. An injection, $400 to $600. Some cases $300 if you're very lucky. And that's going to include your office visit fee, the copay, or the total cost if you have a high deductible, and then the cost of the films. What if your physician wants to get an MRI? Now you're pushing $500 to $800. Clunky orthopedic shoes, like the big New Balance ones, those are like $200 to $250. Custom inserts, those go from $400 to $500. My clinic, I think we charge $300 or something like that. But those are expensive too, and they take a long time to come in now, particularly because of the supply chain. So it's an option for some people, but remember I told you foot strength's better. Physical therapy, I didn't even talk about that. That depends on your coverage. I know people that their insurance plan says they cover physical therapy, but the copay is $100 per visit. So do they really cover it? I don't know. So physical therapy is an awesome option, but the cost of it is so wildly variable, I can't even estimate. And then surgery, anything from $3,500 to $15,000. So the treatment is very high cost, and the effectiveness is grade B evidence at the most, with limited efficacy across the board, I think, with the exception of physical therapy. But again, it has to be a really good physical therapist. So what do I do in my clinic? I emphasize natural treatment. Of course, I want to empower my patients. So they have to get their feet stronger. They've got to get more flexible. If they are BMI that's not considered healthy, like 29, 30 or more, pushing the obese zone, because I know that adipose tissue produces painful inflammatory cytokines, I want them to lose weight because I know their pain will get better. Because by definition, they're reducing fewer painful proteins on a daily basis. Supportive footwear is important as long as it still allows you to strengthen your foot and it won't make your condition worse. I'm a huge fan of platelet-rich plasma. So I would say for me, it's getting your foot stronger, more flexible, working on kinetic chain, mostly through physical therapy, offloading the appropriate areas for short-term only while you work on your foot strength, and then losing weight if you need to, and then getting on a natural, healthy diet like the Mediterranean diet, and then taking natural anti-inflammatories so that you don't have the side effects of the things like the gut-destroying NSAIDs and the steroids that cause rupture, hormone disruption, etc. And then platelet-rich plasma is your blood, so you know that it's going to be a good thing for you. We just concentrate it and minimally manipulate it to get you the most platelets possible to put in that zone of injury. So that's a great protocol that we use, and it works really, really well. Of course, I love the flip-flop I designed for, oh, thank you. So talking about all this, you sort of see how I feel about the normal way to treat these things, right? That I was trained to do all of that. But I just found it all to be quite ineffective, and a lot of patients couldn't afford it. I'm from a military family. I was an Army brat. I treated inner city people in residency, and I treat a lot of people on fixed incomes. And you try dropping a $3,500 treatment protocol like that, that's I don't think really ethical. And a lot of times it doesn't work. So I put a bunch of different treatment modalities into this particular shoe to get you where you need to be. So because it's a flip-flop, it's going to increase your foot strength by definition. Most physicians will tell you flip-flops are terrible for you. They're right, but they're talking about the really flimsy ones that don't do anything except provide, maybe half of a centimeter of material between the bottom of your foot and the floor. So this is pretty stiff. It's an EVA foam that's designed to be a certain durometer to promote a bit of cushioning, but then to elastically return to its form so that it lasts longer. But because I made it structural like this, it forces you to use your foot muscles, which I think is very important. It cushions right where that medial band hits, but not laterally. Remember, I told you normally for heel strike, you hit like this and roll. A lot of people end up guarding the whole time and they never put weight here because it's the same differential thickness on both sides, but this way you can stand normally and more of your relative weight will go over here than here, and that helps your heel pain a bit too. A rocker bottom sole, remember I told you that's why the boot really works, I think, but this gives you that ability from the boot without all of the detriments of the boot. Some of these will have a toe lift, sometimes called a cluffy wedge, that lets your foot stretch. We made a version without this because if you have a bunion or hallux rigidus or gout or something like that, or you just don't like this, we remove this, and the guy in this picture is holding that, the Palmer version. And then you can see better the arch support in that picture. It's not a real high arch support because remember I told you you want to strengthen your arch. What this does is it gives you just enough to support you during that forward thrust, but it doesn't take away the elastic restraint and the elastic energy storage of the plantar fascia. And the rocker is letting you stretch the plantar fascia while you're wearing it. And then it offloads the ball of the foot, which if you remember is where the plantar fascia splits and vertically interdigitates into the toes. So it takes pressure off of that zone. All these features work together to sort of help you self-treat. And I just wanted to sort of explain why I did that and how it works in concert, each feature to promote what I think is good for your foot, which is better foot strength, more flexible fascia tissues, and natural healing. And we have a question. Hold, please. Two questions.
I know if you were going to be making a sandal for people who don't like anything between their toes, and it's supposed to get here in June. They can pre-order it now. It's called Emerson.
Okay. Oh, so a lot of people, and I find it mostly men, honestly, but in the South, you'd be surprised. Most men don't care. They still wear a flip-flop. The thong seems to bother people. So the question is, will we have a version without the thong? Yes, the Emerson is coming out in June, which is more like bands and then something around the heel to help. Oh, the two-strap, which is the Emerson?
Yeah.
The Emerson, sorry. I'm thinking of the Everett. It's one with the back strap. The Emerson is going to be more like what I think of as a soccer slide because I grew up playing soccer. You know, the bands that just hold the instep on the foot. So it's like a sandal, more or less. So no toe thong. Either way, you're still going to be able to strengthen your foot muscle, which is my primary concern for most people. So the question is, and I get this question a lot, and we get a lot of social media comments about this, that we are not correcting alignment, or do we correct alignment? So if you remember from this talk, what really corrects alignment is a good, strong foot and keeping the energy transfer abilities of your fascial structures. So this shoe is designed to work whether you have flat feet or a high arch foot. So therefore, I cannot correct alignment with this. Rather, whatever your particular alignment is, this foot will offload with the rocker, okay, and help with that energy transfer. It will cushion where the plantar fascia inserts. I'm not trying to support an arch in the way that you traditionally think of it because I want you to build the strength of your own arch. And then the rocker in the forefoot takes pressure off of those interdigitations of the vertical aspect of the plantar fascia. And then I want you to build your foot strength with this nice structural shoe. And then I want you to have that proprioception, or that ability to sense your position in space. So to me, the alignment of your foot doesn't matter as much. And there's another reason for that. This affliction strikes you whether you overpronate, underpronate, if you're flat, if you're high arch, there is no difference. It hits all of people. So I think that whatever your alignment is, the treatment should accommodate that particular alignment and still work. That's why I did it this way. Now, you may have a physician that wants to correct your alignment. By all means, get the insert they recommend and then use this just as a recovery device or something like that. But no, this is not meant to correct alignment because plantar fascia strikes everyone. All right.
Jill says thank you for your sandal.
Okay, we had somebody that said thank you for the Everett, which is the cross strap in the back with a little strap to hold on the ankle, because a lot of people just feel that they want that sense of security. So we did that for you. And that one is also coming later this year. Again, like everybody else in the business community, particularly small family-run businesses like us, the supply chain has dramatically affected us. So just be patient with us. So again, pain relief. I don't like narcotics. Not a huge fan of the synthetic anti-inflammatories, although they do have a role when needed. I'm more of a fan of natural pain relief, either reducing your own intrinsic production of painful proteins through diet and weight loss, upregulating your omega-3s, upregulating your phytochemical or micronutrient intake through the Mediterranean diet is the number one way to do it. And then I supplement on top of that, because it's difficult to eat 9 servings of healthy vegetables and fruits every day. If you can, more power to you. But it's really hard to get the amount of micronutrients, minerals, vitamins, and other phytochemicals that you need to be healthy and to reduce pain of connective tissue and muscle and whatnot. So again, the Joint Health Multi, that's got the turmeric, the ginger, the PEA. We love tart cherry because of its ability to both reduce pain and act as an antioxidant. And then the Essential Daily Vitamin has all of those molecules we talked about, vitamin C to help the cross-linking, D3, which is really sort of effectively a hormone because there's D receptors on most tissues in the body. Calcium, magnesium, zinc, all of these things help connective tissues perform and keep their superstructure of collagen, which is a tightly braided protein structure that has a certain number of crosslinks that are good, a certain number that are bad, has to have a certain ability to elastically deform and come back in size. It's all very mechanical, and if you don't give them the builder, the body, the right materials, the bridge is going to fall apart, or the connective tissue. So think of it as a mechanical structure that just needs the right pieces and parts. And that's why I think the Mediterranean diet is probably the best. And then all of these other adjunctive supplements. And then if you end up having plantar fascia anyway, if you're unable to prevent it, my first line of treatment for you would be physical therapy, something like this, getting your foot stronger. And then potentially, if you had to, maybe do a PRP injection. We have a question. Yeah, so the question is, if I don't have heel pain or plantar fasciitis, can I wear the shoe? I wear this shoe all summer when I'm not in my work shoes. So yes, I don't have heel pain, but I wear this because I want my foot to be strong and I want to keep my heel cord flexible as much as I can. So when I wear this, like if I'm standing, I'll drop back and stretch my heel cord. And I love this because it puts my weight in the middle of the foot and it just takes all the ball of the foot pain off. Remember I told you I played soccer for years and years? I tend to have pain on the ball of my foot, particularly on my left foot under the 4th and 5th, probably because that was the main plant foot. Although I could kick with left and right, I usually kicked with my right foot. So I'll wear this to offload that part of my toe whenever it flares up, gets better, and I don't need it anymore. But yeah, so remember the goals for you: foot strength, flexibility, and natural healing. You're injuring your foot all day, every day at a microscopic level, right? So yes, anybody can wear this. It's great for foot health. It's just in particular using modalities that would take you probably 6 or 7 visits to the doctor to build this all, because they're going to start with a boot, then they'll do an insert, then they'll do a cushion, then they'll do an injection, then they'll do stretching, et cetera, et cetera. So hopefully it just saves people with heel pain time, but it's definitely good for your foot regardless. My opinion. I'm biased, of course, because I designed it. Another question. This is good because I like questions. Okay, we have a good question. So the question is, to whom should you go to diagnose plantar fasciitis? And I presume you mean what type of physician? So honestly, I think a lot of physical therapists are underrated and they have a very deep knowledge, particularly if you find one that's treated foot pain, or even some of the sports chiropractors are really, really good. And they'll take the time to actually be hands-on and do a real exam. More so than most doctors who are forced to see 50 to 60 people a day by their hospital employers. So physical therapy, don't forget them. Maybe start with them because they might be A, more accessible, B, cheaper, and they might actually do a physical exam. I am an orthopedic surgeon with a subspecialty training in foot and ankle surgery. So I did a fellowship for a year in foot and ankle surgery. I would say an orthopedic surgeon with foot and ankle experience is probably a good choice. And then podiatrists are great choices. I mean, obviously, they understand the foot at a very deep level. So any of those three are fine, whichever you could see first. And like anything else in medicine, and I think I've done a talk on this, you also might want to get a second opinion because all of us have different training. All of us maintain our education at different levels. Some of us read all the time. Some of us don't. Some of us go to meetings. Some of us don't. So you may want to get a different opinion. It's an art, not a science. I know the insurance companies and the government think that every single physician is the same and every single physical therapist is the same. But as you know, and I know, that is not the case. So second opinions are also helpful. But I would say physical therapy, orthopedic surgeon with foot and ankle subspecialty training, podiatry. Okay, I think that's it for this talk. Hopefully that gave you sort of a baseline of what the plantar fascia is, what it feels like when it's inflamed or hurting. What are your treatment options? Why you may or may not want to use those treatment options, and maybe some self-care methods that you can employ at your own discretion. And then I would just leave you with this. Just remember your heel cord, the Achilles. That is one of the primary drivers of most foot pain in America. So if you can keep that stretched at the very least, I think you'd be doing yourself a huge favor. And try to cook your own food from whole sources and don't eat highly processed foods. And you'll reduce all of that microscopic inflammatory and oxidative stress damage to your fascia. Those are the two basic things you can do for yourself. Stretch your heel cord, eat a Mediterranean diet, and then take it from there with this talk. Hopefully that helped you. And oh, my Aunt Janet is watching this. Hi, Aunt Janet. She said, good job. That makes me happy. All right, everyone. Take care.